So welcome everyone. Tonight's webinar is entitled Labor Induction Explained. And my name is Allison Rollins. I am a doula and the co-owner of High Country Doulas, a wonderful doula agency that has a team of doulas to help support women and their partners through pregnancy, labor, birth, and throughout that postpartum period as well. So we want you to feel prepared and understand what your options are, anything from understanding cesarean birth to understanding if you might have an induction. Also, we support moms who are trying to have vaginal birth after cesarean, VBAC. We also support moms who are going to have scheduled induction and also a non-medicated birth, if that's their choice. So we have lots of different types of tools that we can use as doulas to help support moms. And one of the biggest tools that we have is resources. So understanding what's normal, what to expect, how to navigate those bumps in the road as you go along, because there always will be bumps. Some of them are little and some of them are big. And we want you to feel like you know your choices, understand how to make the choices with that information, and your team, which includes your provider, your nurses, each other, and any other support that you have, such as a labor doula or family and friends. So welcome. I'm so glad that you're here tonight. Again, my name's Allison Rollins, and I have the privilege of supporting people throughout this transformative time. And as with any transformation, the decisions that we make are unique to us and based on what we feel is best. At High Country Doulas, we offer education as well as support for those decisions. So who's up for some valuable learning tonight? Super excited that you're here. All right, so welcome again. I just want to say that within the topic that we're dealing with tonight with induction, typically a lot of women may not know that they're recommended to be induced until later on in pregnancy. So depending on where you're at, you may have had that presented to you as something that may be a recommendation for the health of you or for the health of your baby. You may be concerned about that. You may be worried. You may have a friend who was induced. And people share their stories because birth is a part of our life and important, but sometimes that can lead to us worrying about something that might not be the path that we take. So I want you guys to understand it. Tonight's webinar will go through a lot of things of what if in that scenario these are reasons why you could be recommended to have a labor induction. A lot of them are very rare or not typical, and some of them may be more typical. So we will talk about that as we're going through this. Please write down any questions that come to mind, and we'll definitely address those if they don't already get addressed in the webinar tonight. So glad you're here. Let's go ahead and get started. All right. Oops. There, sorry. If you're here tonight, you're just likely very curious about what an induction of labor entails. So you may have heard all of those stories that I mentioned, positive and negative, and perhaps you may be also facing that labor induction. But tonight during our time together, we're going to really take a closer look at the methods of labor induction. We will learn why a provider might recommend it and why a pregnant person might ask for one, and what are the various approaches to labor induction. So this webinar is really going to help you understand each aspect of that. First, let's take a look at why an induction of labor might be necessary or desired. There are really two main categories for induction of labor: medically indicated and elective. There are many medically indications for induction of labor. During your pregnancy, your provider will be or is closely monitoring your health and the health of your baby. If you or your baby develop certain risk factors or complications, they are going to recommend that induction of labor based on what's going on with you medically or your baby. And they will weigh the risk and the benefits of induction at that time. For some expectant individuals, inducing labor may be a choice that they make for themselves and their babies, and they may not have any risk factors or complications. Some people refer to these types of inductions as social inductions. A person may choose kind of to have an induction if they have a partner who travels and would not be able to, they want them to be there on the day of that birth so their partner can be present. Others may choose to have an induction because they live far from the hospital and have a concern about the commute during labor. You know, with the weather, sometimes that is a factor. Others may have a history of rapid or precipitous labor and feel like an induction will prevent them from not help them get to the hospital in time and be there with the support that they want. And sometimes an induction is scheduled because a pregnant person wants to make sure that a specific doctor or midwife that they prefer is on call for their birth. I would say that this is, depending on your area, is not as much of a possibility. But we do in the winters in the mountains, we can have weather, and some people will drive a really good distance for their births. So that can definitely be a factor. All right. So I can't move forward with this without talking about partner support. When we look at partners support, and that can be not only the mom, but also the, hold on one second. Just making sure everybody's muted. All right, guys. Okay, perfect. Okay, sorry about that. Just want to make sure we don't have any static. So regardless of the reason why we find ourselves on the path to induction, we need to understand the emotions that can surround that time, like whether those emotions are excitement or worry or fear or grief and loss, doubt. Anger can also be a part of that, relief, right? Or whatever you're feeling, you can take that time to ask each other, because we all are going to have really strong emotions surrounding birth. Sometimes, you know, you can take the time to say, how are you? You know, what are you feeling right now? I'm feeling blank, blank, and blank. Acknowledging partners' feelings and asking the questions like, what questions do you still have? Helping them to feel at ease and moving forward can be beneficial for both of you. So if you're faced with an induction, consider making sure that you're listening to one another, that you're hearing each other, and acknowledging each other's feelings can be really important in moving forward with that birth and how you go into that birth together. So just want to say that from the doula perspective, I think it's a very key factor. So let's take a closer look at those other risks for what we talked about, the medical side, medical induction side. All right. Many providers do recommend a medical induction for an expectant person who may have type 1 or type 2 diabetes or gestational. And a couple of reasons are stillbirth and preventing baby's growth to be too large. there's really there's a lot of debate about this among the childbirth community about the necessity of induction to prevent these things in individuals who do have well-controlled glucose levels, because the studies are based on these large populations, and the decision to induce is really on a case-by-case basis. So if you are somebody who has one of these, it's really good to kind of discuss this with your provider and kind of weigh those benefits and risk with them moving forward. Right. Another reason birth is often depicted in the movies and on TV is sort of this big event where your water breaks dramatically and you rush around with your like just frantic pace and like figure out like, we've got to get to the hospital, we got to go, you know. But in reality, birth looks very different for most birthing couples. Only about 10% of births begin with your water breaking. But premature rupture of the membranes is a reason sometimes that an induction could be recommended to you. And that is when your amniotic sac or bag of waters breaks before the onset of labor contractions. When it breaks, sometimes there's basically two approaches that your providers might take with that. There's two different types of what they call management. Expectant management would be allowing time for labor just to kind of start on its own. They may be monitoring mom for temperature and vitals and monitoring baby during that time. A more active management approach that your provider could choose or offer to you would be to augment labor in some way. So if you have GBS, group B strep positive, a lot of providers will want to begin antibiotics as soon as possible after the bag of waters is broken. And they, some will still like watch and wait 12 to 24 hours, you know, in that space. It's something that if you're in that space, it's a good idea to know the policies of your birthing center where you're going to deliver on premature rupture of the membranes. And this will also depend on like what weeks you are, of what course of action they will take. All right. Fetal growth restriction. So this is typically defined as fetal weight that falls below the 10th percentile for gestational age. Other terms that refer to fetal growth restriction are intrauterine growth restriction or a baby who is too small for their gestational age. So when a provider is concerned that your baby may have a growth restriction or be too small gestationally, then they try to identify what type of growth restriction your baby might have. And there are two basic types of growth restriction. Asymmetrical growth restriction is diagnosed when the baby's head and brain are normal size, but the rest of the body is small. And then symmetrical is when the all of baby's body parts are small in size. This can be caused by a condition called placental insufficiency, basically meaning that the placenta is not functioning well and transferring nutrients and oxygen to allow for normal growth of the baby. Other possibilities are such as multiples, smoking, drinking, high blood pressure, and maternal infection, health conditions, nutrition, genetic disorders, and potentially exposure to certain medications. Right. Chorioamnionitis, I believe that's how it's pronounced, is basically an infection of your amniotic sac and the amniotic fluid. It can occur when the bag of waters has not yet broken. It affects up to 70% of preterm births, so like before 37 weeks, where the bag of waters has broken before labor begins. So if somebody had early labor and their bag of waters broke, it can sometimes be associated with chorioamnionitis, which I can't really pronounce, but this does only affect, this specific thing only affects about 2 to 4% of full-term deliveries. So it's a huge dramatic drop if you carry your baby to term or near term. The source of the infection is typically due to a bacterial infection, sexually transmitted infection, or group B strep. So those are some of the causes of this. Antibiotics are usually the first course of treatment, depending on the gestational age of your baby. And the typical course of treatment is to deliver the baby either via induction or cesarean. If left untreated, it could lead to other complications for mom and for baby. So antibiotics are given during labor and continue for a time after labor for mom and the baby. If the baby also has any signs of infection, they will be treated with antibiotics as well. Other reasons why you might get recommended to have induction would be high blood pressure during pregnancy. It's really often referred to as gestational hypertension. Providers classify that into 3 different categories. So one is chronic hypertension, gestational hypertension, and preeclampsia. Chronic is defined as a person who has high blood pressure at or over 140/90 before pregnancy, or before the 20th week of pregnancy, and continues to have it after the birth of the baby. Gestational hypertension is defined as high blood pressure that begins after the 20th week of pregnancy and does not continue after the birth of the baby. The third, preeclampsia, is a serious condition that includes high blood pressure and protein in the urine that develops after the 20th week of preeclampsia. So this is one thing that those urinalysis tests that you do is checking for as well. It can lead to more serious health condition called eclampsia, which could cause seizures and death. So these are more rare. They're monitoring this at all of your prenatal visits to make sure that you do not develop this. And rare cases, I have had one client who has had this. It can develop into what's called HELP syndrome. It's named after the symptoms of hemolysis, elevated liver enzymes, low platelet, and can cause serious complications both for the pregnant person and their baby. So you would know, they would talk to you about this if you did develop preeclampsia. Right. So intrahepatic cholestasis of pregnancy, or ICP, is also a reason that you might be induced. It is a liver disease that only pregnant individuals can experience. It's also known as obstetrical colitis, or OC. And it's caused by a disruption in the flow of bile in the liver due to those increased hormones of pregnancy. Many expectant individuals with ICP experience intense itching of the hands and feet, and fatigue, depression, loss of appetite, and pain in the upper right abdomen. If any of you out there are Call the Midwife fans, the lady who plays the blonde nurse, she developed this in her pregnancy, and I watched an interview with her. And she was talking about how she just started itching really bad, like her hands and different parts of her body were itching. And a friend of hers said, "You probably need to have that checked out." So it was really nice to have a friend who was supportive of that. And she did not realize that she had it. So about 1 in 140 pregnant women get this, or 0.7%. It does increase your risk of issues for the baby. So they do often do inductions for this. All right. Oligohydramnios, I believe. You can tell I am non-medical. Doulas are not medical, but we know a lot of different things. So this condition basically is known as low amniotic fluid, and this is a very common for some people, depending on, it is a commonly listed thing as a reason for induction. Actually, about 4 out of 100, or 4% of people who have this, and about 12 out of 100, or 12%, to deliver beyond their due date, so 40 weeks or beyond. Your provider is going to determine this as a result of an ultrasound or a biophysical profile at any time during your pregnancy, but it is most common in your 3rd trimester. You may have a friend who's been told that they have low fluid. I've had several clients who have had low fluid as a reason for induction. So sometimes they'll monitor it, and sometimes they feel like it's low enough to recommend an induction of labor. Causes of this could be post-date pregnancy, placenta insufficiency, premature rupture of the membranes. You may have had like a high leak or break rather than that big gush and not really note it, just having a really tiny, almost like pinhole breaks, and that amniotic fluid just leaks. Maternal complications such as dehydration, diabetes, preeclampsia, and high blood pressure. So it's really important, especially as we move into these winter months, to make sure that you keep your immunities high, exercising, eating healthy, drinking well, and eating lots of very wonderful greens, all those good vegetables, just colorful plates. Can be really helpful in taking your vitamins, getting your flu shot, all that stuff to protect you from getting sick, because that can definitely make I've seen that be a factor in women. The things that low amniotic fluid may result in are intrauterine growth restriction, preterm birth, and cord compression. So they will be monitoring and checking all of that for you. All right. Another reason for induction is post-date pregnancies. In 2013, ACOG and another group kind of defined term pregnancy. They convened and did this review and research. And a result of their review, they divided term pregnancy into 5 different groups. So we have late preterm, which is birth between 34 weeks, 0 days, and 36 weeks, 6 days. Early term would be birth between 37 weeks and 38 weeks, 6 days. Full term is considered 39 weeks and 40 weeks, 6 days. Later term is birth between 41 weeks and 41, 6 days. Post term would be 42 weeks or later. So make sure I got all that. So as you approach your due date, your provider may begin to open up that conversation about induction if baby doesn't come. And so I often tell moms, like, don't be scared about that. Like, just know that your body knows what to do. They're going to be monitoring and checking in on you. Some women have early signs of labor, and some women just start labor without a lot of other signs. So it's not something that we can control. And it's really supportful to have people in your life that say, it's okay, you're going to do this. And we'll talk about this a little bit later, but inductions can be very wonderful births and still be able to gain whatever your goals are with birth. So just kind of keep that conversation open with your provider. After about the 39th week of pregnancy, there is a very small increase in the overall rates of stillbirths. So there's not a huge risk there, but the risk does rise at 42 weeks in about 1 in 1,000. So providers are really wanting to monitor and make sure you're healthy and your baby is healthy. Induction of labor for post-date pregnancies is a decision that's best made in conjunction with your healthcare provider. And they do closely monitor you if you're going over your estimated due date. I will say that there have been recent research that the best estimate of your estimated due date is your very first early ultrasound. It's better than using your period, because not everybody has the same number of days that they have in their period, and ovulation can occur differently. But that very first ultrasound is a really good and more accurate indicator of your actual estimated due date. Right. A non-stress test. Some of you may have already had this. A non-stress test is really an assessment for your baby using 2 monitors attached to your abdomen. One is the TOCO, and the other one is your external fetal monitor. So the external fetal monitor measures your baby's heart rate, and the other measures your contractions. So in approximately about a 30-minute window, they will monitor baby's movement, heart rate, and the response of their heart rate to their movements. During this time, the test is considered either reactive or non-reactive. So this is why we're saying that if you have a non-reactive non-stress test, then your provider may recommend an induction of labor due to the lack of reactivity from your baby. Right. A biophysical profile, or BPP for short, is a detailed ultrasound that is combined with the non-stress test. The biophysical profile does measure your baby's muscle tone, movements of your baby's body. It also measures breathing movements, so that expansion of the chest, measurements of the amniotic fluid volume. The baby will be given a score based on the following 5 categories. Each category is given a score of either 0 or 2. Okay, 0 being abnormal, 2 being normal. And the 5 categories include heart rate, body movement, amniotic fluid level, muscle tone of the baby, and those breathing movements. So a score of less than 6 may result in a recommendation of induction, and 10 is the highest score that you could get. And in some cases, women will be given what's called a modified biophysical profile that only measures amniotic fluid levels and a non-stress test. All right. So Bishop score. If you've been in my childbirth ed class, you probably know what a Bishop score is. I hope you do. I talk to all of my clients about a Bishop score so that if they are wanting to ask questions, they understand what their provider is talking about. So one of the risk factors that providers look at when deciding how to proceed with induction is your Bishop score. They don't necessarily want to tell you your number. They'll tell you that you have high Bishop score, a low Bishop score. And the Bishop score is an assessment scale that is used to determine the likelihood that an induction will be successful. And just tells how ready is your body, how ready is your baby to be born. The Bishop score is calculated. Oops. Hold on just one second. Okay. Just needed to mute that real quick. So the Bishop score is kind of an assessment scale used to determine the likelihood. And the Bishop score is calculated by looking at 5 different measurements during a vaginal exam. So when you're having a cervical check, which typically providers are not doing this as much unless it's specifically necessary to you, but as you get closer to that estimated due date, they may offer or ask to do a vaginal exam. And the measurements that they're looking for here are the dilation of your cervix, which is the opening, the effacement of the cervix, which is the thinning, the baby's station in the pelvis, which is based on where it is it high or low? And I'll talk to you a little bit about that after the end of this if you have any questions about that. The consistency of the cervix. So consistency, we're really looking at how does the cervix feel? Does the cervix feel like the end of your earlobe, right? Or does it feel like the tip of your nose? So is it have a more of a firmer consistency or a very kind of soft and squishy consistency? And then also the position of the cervix. That means, is that cervix in its posterior facing your spine, or is it kind of shifting towards anterior? All right, so we're looking at, with that Bishop score of 8 or more, gives you a favorable, tells that your provider that your body is more favorable for an induction, okay? And a Bishop score of 6 or less can indicate that the cervix is not favorable or ripe. And it also doesn't mean that you might not still get recommended for an induction, but they may focus more on the ripening aspects, ripening your cervix versus other possibilities. All right, so let's go ahead and take a look at these ripening methods, because based on your Bishop score, if you have an induction recommendation, then you may be proceeded to have what's called cervical ripening methods. Really, regardless of the reason, many options really exist nowadays to kind of initiate labor. And you should keep in mind that not all the options will be available in your location. So it's always good to have that conversation with your provider about if you are presented with an induction of labor, asking them what tools they have and how will they be used in what order. So providers are happy to kind of walk through that with you. I do this with my clients so that they kind of understand what to expect with that. So some providers may have a preference for one method over another based on a variety of your health and your readiness factors. Other times it could be what drugs are available at that birthing facility. So I often do recommend that clients understand how ready they are. And so that's why I reviewed all of those things like the Bishop score. And it can make a huge difference in how you feel about going into it and how your body kind of, the riper your body is and the more ready it is, the more likely you're to have a successful induction. So your providers are really looking at all those things. All right. Let's talk a little bit more about them. First, we have stripping the membranes, okay? This is a method of induction used to try to trigger the release of hormones, those prostaglandins, to help soften and open the cervix. It is a procedure that is most commonly done in your provider's office during a pelvic or cervical exam. You do need to be about 1 centimeter dilated, like a fingertip dilated, for your provider to be able to strip your membranes. They're basically going to insert a gloved finger into the opening of the cervix and attempt to gently separate those tiny little capillaries that adhere the bag of waters to the top of the cervix located inside the uterus. And this is really intended to trigger the body to release those hormones that might cause some uterine contractions and result in some more softening and thinning or effacement and dilation or opening of that cervix. So it is, for some women, quite painful. So if you are getting to that point in your pregnancy and you've talked about it and you think that might be something you want to do, always take somebody with you to that appointment. I think it's very helpful to have somebody there with you as you're going through that. So another thing that's called the sweeping the membrane. Some providers will call it that. And this does not typically result in labor starting, although there is a chance that it will initiate. It is within the scope of normal to feel cramping, mild cramping, and to have contractions and spotting for 24 to 72 hours after the membrane sweep. This bleeding can be brown, pinkish, spotty, and is often mixed with mucus. It can also cause, rarely does it cause the sac to rupture. there is some more information, and I'll send you this in the email, in a Cochrane review about sweeping the membranes and some research on that. Some providers will do this more often than others. So it might be something that you want to check in with your provider about, like how often do they do that? And some women want it done and others are like, oh, I don't think I want that done. So just let them know what your preference is with that. Just consider how you might feel about it. With anything, sometimes your emotions surrounding things change as you get to different weeks of your pregnancy, and that's normal, and it's okay to change your mind about things. So important to leave that kind of avenue open. Let's talk a little bit about ripening devices. So in order for the cervix to respond to contractions, it needs to make a number of complex physiological changes, which I love to talk about. Relaxin and estrogen initiate these sort of structural changes, and prostaglandins, leukocytes, macrophages, and hyaluronic acid and glycosaminoglycans are all involved in the softening of the cervix for labor. So when the Bishop score is low, the cervix really is going to need to be ripened before an induction can begin. And some providers will recommend the use of a mechanical method of cervical ripening. A couple of different methods could include a laminaria stick, I think I'm pronouncing that right, and a Cook or Foley catheter. So the laminaria stick is a form of, let me show you here, it's here on the left. It's a form of seaweed that absorbs moisture. The stick is a bundle of compressed seaweed that inserted into the cervix. And then this is in place. The stick will absorb the moisture from the cervix and surrounding tissues. This is intended to cause the cervix to dilate and soften as the laminaria expands. I haven't personally ever had a client who's used this, but it is fascinating, and that's why I put it on there. So I don't know if that's available at your birthing center or not. The Cook or Foley catheter is a cervical ripening balloon that is made from silicone with inflatable balloons at the tip to encourage the cervix to thin and dilate. And it ripens the cervix for labor. The catheter is inserted into the vagina and into the cervix. The first balloon is inflated inside the uterus at the top. This is showing a one balloon, so these diagrams may be different, and your Foley catheters may be different depending on where you deliver. But anyway, so it's inserted into the cervix. And again, similar to the stripping of membranes, to get the Foley bulb catheter, you have to be dilated enough for your provider to be able to insert it. So it may not be something that they can do until your cervix dilates a little bit more. So the first balloon is inserted inside of the uterus at the top of the cervix, where you can see here, right here, you can see it inserted there. So it's just below the baby's head. And the second balloon is inflated against the bottom. So some of these have a balloon down here in this area as well. And so it's compressing that cervix to open and soften. Does that make sense? And it's typically either has air or saline solution that inflates it. So there's no medication in that. It kind of puts this continuous pressure on the cervix, and the catheter will typically fall out once dilation reaches about 3 to 4 centimeters. The Foley catheter does look much like the Cook catheter, except the Foley only has one balloon. So you can see here that this is the Foley. The Cook's catheter is one that just basically has another balloon down here. All right. So once the cervix is considered ripe, Pitocin may be considered to continue that induction process. All right. So ripening medications. In some situations, providers may prefer to use a medication to ripen the cervix, and these medications called prostaglandins are not meant to trigger labor. Instead, they are intended to cause the cervix to become softer and thinner. Prostaglandin medications that are used for ripening of the cervix may include misoprostol or cytotec or dinoprostone, which is Cervidil. Depending on where you're delivering, there may be different options for you. The cytotec is when providers first started using it, as it was an ulcer medication to begin with. The safe dosage had not been established as a part of standard of care, and as a result, there were many complications due to too much medication of the cytotec being administered. But over the past decade, there have been numerous clinical trials and studies to determine a sort of standardized dose and standard of practice using the cytotec for cervical ripening. And it is typically given in two different forms, either an oral slurry or a vaginal tablet. Sometimes it's given as an oral tablet too. So when given for it, it's typically the oral slurry drink is given at 25 micrograms every 2 hours, or the vaginal administration of 25 micrograms every 6 hours. The Cervidil, which is another medication, is a vaginal suppository that is used to ripen the cervix as the first step to induction. So a lot of moms that I work with in certain hospitals, they will go in at night, like 6 p.m. to be induced, and they will be given Cervidil. And Cervidil is inserted. It looks kind of like a little cell with a tail, if you've ever seen under the microscope. But it's an suppository that has like a string, and they kind of wrap that up around the cervix, kind of like a small flat tampon, about the size of a paper clip-ish. So they're going to insert that, and then oftentimes they'll want you to sleep overnight and let that cervix soften and ripen. So one of the things I often tell moms is, like, you probably want to get as much rest as you can. So if you're having trouble sleeping, it's okay to ask for or take a recommendation of something, medications to get you to sleep that night, whether it would be Benadryl or something else. Providers know that you're going to need lots of rest, and they're really wanting you to get the rest that you need for that next day. So one of the benefits of using Cervidil over other ripening medications is that it can be removed. Once the medication is removed, it can clear one's system in just a matter of minutes. The possible downside is that you will typically need to lay down for a period of time after it has been inserted. Some individuals also report that the medication can feel irritating to the internal vaginal tissues and extend into your labia minor and the labia major. Like the misoprostol, the Cervidil helps to soften, open, and thin the cervix so that it may become ripe for a better likelihood of a successful induction. So ripening is definitely your friend when it comes to labor inductions. All right, love this picture in the stirrups. Another tool that your provider will have is breaking your bag of waters. It's also known as amniotomy, or artificial rupture of the membranes, or AROM. The amniotic sac is like a bubble, that watery bubble that your baby lives in, and it contains amniotic fluid, placenta, umbilical cord, and the baby. It is made up of two layers, the amnion and the chorion, which you talk about earlier with the chorioamnionitis. When the bag of waters is broken, the amniotic fluid is released, and the fluid contains chemicals and hormones that may stimulate labor once released. When the waters are broken, they also allow the drainage of fluid that help cushion between the baby's head and the cervix. So as we saw in that picture a couple back, oh, I can't, sorry. Well, yes. So you can see here in this picture, I'll use a little hover key. So you can see baby's head here. So imagine you can see the sac a little bit there. So there's this sort of sac that cushions baby's head from the cervix. And in a lot of ways, that's really great for baby, but it's also not a hard, firm thing pushing on the cervix. So sometimes the cervix will respond to thinning and opening and dilating, all of that a little bit better with that hard head. So this is just a tool that when we're talking about breaking the bag of waters, and your provider offers that as an option, it's kind of just letting you know what that's doing. That pressure on the baby's head on the cervix can really help sometimes with dilation and effacement. And it may also do what women really hate, but it's really good for birth, is that it may trigger some more intense contractions. So if this is something that is recommended to you in your labor or in an induction situation, partners really need to be there. Doulas know this, but we need to be there to support mom, because it may shift your labor completely. And you want to be in a good space with lots of good support at this time. And if you're getting ready to get an epidural, you might be the time that you want to do that. So, all right. So typically what a provider will use for this is an amnio hook. It looks kind of like a crochet hook, and they're going to do this during a vaginal exam. Sometimes the bag of waters is so thin that a provider can kind of snag it and it'll pop. Occasionally this is done in labor, just FYI, without your consent. So if you are in a situation, always ask them when they're doing if you do not want this done, always ask them when they're doing a vaginal exam to remind them of your wishes for that. Because in labor, you will have providers and nurses who will be doing your cervical exams. Right. So when this happens, you may have sort of these small or large gushes of fluid from your vagina until your baby is born. Some providers will use this as a first step to labor induction when the cervix is ripe and they feel it is safe. So the providers don't want to have your bag of waters open for a really long time, because it can open up your baby to infection. And so they consider like where you are in your labor. Is this your first baby, your second baby, your third baby, and so on. All right, another option that your providers will have is Pitocin. And everybody's heard about Pitocin. Mostly it's all been negative, but Pitocin can really be your friend when it comes to labor induction. And Pitocin is basically synthetic oxytocin. So as a doula, I am like the lover of oxytocin. Oxytocin bonds us, it makes babies, it brings babies into the world. It's just an amazing hormone. So since we realized that it's such an amazing hormone, we started using it, synthesizing it to use it to help moms have babies when they need to be born a little earlier or need some support with that. So this hormone is given via IV to stimulate those contractions and induce labor. So once your cervix is favorable or ripe and soft, your provider is going to order a Pitocin drip that is on a metered IV pump. The medication is typically started at a low dose, like 2 or 4, and then it is increased in regular intervals, depending on what your birthing facility's policy is that, or your provider's policy. That may vary anywhere from 20 minutes to 40 minutes, bumping that up. So something that questions you could ask your provider about that, and what's the standard increase in Pitocin for induction. So the goal of the Pitocin and that drip is to stimulate your contractions. That will come every 2 to 3 minutes, and they're strong enough to cause your cervix to change. So they're looking for a nice, consistent pattern of strong, fairly close together contractions, and the medication will be increased until an adequate labor pattern is achieved. So during a Pitocin induction, a lot of providers are going to prefer that you and your baby are monitored closely. Some providers will allow intermittent monitoring, but most are going to prefer to monitor continuously. How quickly the induction will progress is not able to be determined ahead of time. So for some individuals, just a whiff or a puff of Pitocin is all they need to get their body kicking into gear. And for others, the induction process may take hours. Some women respond to Pitocin really quickly. Others don't necessarily respond either at all, or they're a lot slower. And you don't know that till you're getting in there. But definitely the riper you are, probably the closer to your due date you are, the more likely what your Bishop score is will make you more favorable for having good results with Pitocin. If your desire is to avoid pain medication, a gentle approach to induction, as a doula, we can help increase your odds of success with that if you are trying to avoid that. So if you guys have any stories about Pitocin or have any questions about it, share it in the comments, definitely. So I'm going to send you all in the email the resources of the locations that were used to build this webinar that you have joined us tonight here for. I'm super excited that you all came and spent your time with me. We love to answer questions and help support moms and partners as they navigate their pregnancy and labor and birth. So let's talk. I'm going to take us off of here so we can chat. I think a lot of parents want to know like what to expect when it comes to labor induction. So what kind of things, if you want to ask questions, feel free to take yourself off of mute. Nobody had any questions in the chat bar. If you want to find the chat is located down, if you'll hover down the lower part of your screen, if you're on a computer. I think if you hover to the top or the bottom, if you're on a cell phone, you should be able to find the chat bar. Awesome. Thanks, Rachel. That's really sweet. I know that induction can be something that parents have lots and lots of questions about. And as a doula, helping answer those questions and walking through, what do I need to ask my provider? What's that going to look like for me? There's so many different scenarios of like why you may be recommended to have an induction, but I've definitely had a lot of successful inductions with clients who still want to have vaginal or even unmedicated birth. So if that's something that you're interested in, feel free to ask those questions. Okay, so Jacqueline asked which induction methods or method has the lowest associated risk? That's a great question, Jacqueline. In my experience, I would say if you're speaking about risk to baby and mom's health? Are you talking risk of being successful in a specific birth, like to have a vaginal birth? Typically, providers want you to have the birth that you want, and so they are going to use those tools that they have to be able to do those. And I've had a client who has had several courses of ripening because maybe the first or second didn't work, and they knew that they needed to get that progress done before they were going to have a successful induction with adding Pitocin to that. Some women's response to medications, they can have side effects to those. So it's never, there's never one, I wish I could say that there's typically one thing that works better than others. I think it's really hard to know. Some women are totally okay with stripping the membranes, and some women are like, nope, I don't want to do that. I don't like vaginal exams. So there's lots of different options, but sometimes I think it's easier to kind of use what are the benefits of this option for me and the risk to myself and my baby. You know, adding in medications medications have side effects. Some of them have more frequent side effects than others. Typically, I haven't seen any negative side effects in my work with the ripening methods that I went over. The Pitocin can sometimes have side effects. Side effects that I've seen are nausea, itching, shaking, just feeling out of sorts. And then some moms don't have any side effects. So it's so hard to know with those sort of medicational side effects. I've seen breaking the bag of waters have a wonderful effect on the progress of labor. They say, I think that breaking your bag of waters could shorten your labor by, I think, 30 minutes, either an hour and a half or 30 minutes. And in some cases, I've seen breaking the bag of waters put baby in distress, and mom ends up with a cesarean section. It's like you can't know everything of what's going to happen. So you just have to kind of make those decisions as they come in during birth with the best information and asking those right questions that you need during when it's happening. So Sabrina asked, you mentioned stripping the membranes. Doesn't typically result in starting labor. Do you know a rough percentage of success rate for stripping the membranes? I don't offhand, Sabrina. Typically, I try to go to either evidence-based birth or go to ACOG or National Institute for Health. There's some really good evidence-based research in those sites that you can get for that. So that would be where I would look. So Tiff, you're asking, sometimes it is necessary, however, isn't it best to avoid interventions? So there are a lot of people who talk about like the cascade of interventions with birth, and we have to look at birth on a case-by-case basis based on what kind of health concerns, what are the reasons why your provider is recommending that you have an induction, and you know, how much time are they willing to give you, and how is your health and the health of baby. So if it's something that is like, you know, a mom has preeclampsia, and she's not doing well and her blood pressure's not doing well, you know, that's a more serious situation than some of the other reasons that you might get induced. And a lot of times providers are really willing to work with you on, do I have to do that now? can we wait an hour and see what happens and see what progress I make on my own? I know that I've been in instances where when that Pitocin was added, baby didn't do well. And so a lot of times the provider wants to make sure baby's doing well. So we just turn down that Pitocin for a little while, let baby kind of get back heart rate good and move mom's position and stuff. And then just start that Pitocin up a little slower. So you may not have the biggest contractions, but you're just going to make a little slower progress, but we're also maintaining that baby's doing well throughout that. So, and then we have to balance, like, how's mom feeling, you know, and how's baby doing? So they're looking at so many components when it comes to birth. But, you know, that's what I do, like, in my role, is to help moms who want to, you know, have a specific type of birth or try to avoid specific things in birth. But I can't always control that, but I can make mom comfortable and make her feel good about the choices that she needs to make in those situations in a fully informed way, which is really important. I think when you go through anything with your health, it's nice to know all of your options. So, well, thanks everyone for joining me tonight. I'm so glad that you took the time, and sorry if I kept you guys over. So, any other questions that anybody has before we get off tonight? All right. Just definitely note that induction is something that could be a route that you take, and just don't assume that it's going to happen for you, but your provider will talk to you specifically about that as you move forward, because they want you to know what to expect. But it doesn't mean that you'll end up with an induction. So a lot of times babies just come when they're ready. All right, thanks everybody. If you have any other questions, feel free to email me at info@highcountrydoulas.com. Everybody have a great evening, and come see us at our classes, our live classes. All right, y'all have a great evening. Bye.